Hello, PCR Online. We're here live from Philadelphia at the American Heart Association, day 2. Francesco and I are going to give you a quick wrap-up. I'm Mirvat Asnag, interventional cardiologist working in Saudi Arabia.
I'm Francesco Costa, interventional cardiologist working in Messina in Italy.
So earlier today they presented the NCDR data on the use of Impella and intra-aortic balloon pump in acute MIs in patients who present with cardiogenic shock.
This is a very important topic. We have very few evidence on this. There is actually no evidence that benefit one device over the other. What were the main results of this analysis?
Yeah, so this was an observational study that actually showed more deaths and more bleeding in the Impella arm, even when they used propensity scores to adjust for the differences, and the baseline characteristics were effectively the same.
We could expect that. I mean, there is a huge difference in the number of French of the device, so this is a price that we have to pay for a stronger ventricular support, I guess.
Yes, with the limitations of an observational trial, where you cannot really look at each individual center, how the care in the ICU was, and if that had an impact on overall deaths. So really, this is a call for randomized data that we need in order to continue to use this kind of a technology that's actually expensive.
Absolutely, it's expensive, and the most important thing that we have seen is the experience of the center has a huge impact in this field. Experienced operators that are experienced with large bore access device, very good ICUs, all these things matter. So it's going to be important that this will be tested in a randomized setting.
Absolutely.
So during the first day of the Congress, also the COLCOT trial has been presented. Probably this trial didn't have that much light as the ischemia trial, but it turns out to be a very important trial. We already know from a previous trial that a residual inflammatory risk could be important in some patients after an initial MI, and this has been tested actually in 2 trials now. The CANTOS trial with the canakinumab, with the interleukin-1B inhibitor, and more recently with methotrexate in the CIRT trial. So the COLCOT trial had tested a different strategy. So in this case, the patients have been treated with Colchicine, which is a very old drug that we already use for pericarditis or for gout. Actually, more than 4,500 patients have been randomized in this trial. And actually, the patients have been randomized in a placebo-controlled setting to colchicine at a very low dose, 0.5 milligrams a day, versus placebo. And patients after MI have been randomized. At median follow-up at 22 months, the patients that had been treated with colchicine were associated with a significant reduction of the composite endpoint of cardiovascular death, myocardial infarction, stroke, or urgent hospitalization for angina. This is remarkable because the absolute risk difference that we have seen in this trial was 1.6%, which is roughly a number needed to treat of 63, which is a huge important considering the fact that this drug has shown this benefit on top of the optimal medical therapy that we have today. So the primary endpoint of the study was driven by all the components of the primary endpoint. However, the significant reduction of events was especially seen in stroke, with a more than 70% relative risk reduction, and urgent hospitalization for angina. So this is remarkable.
Yeah, so once again it points to the role of inflammation in the setting of an MI, whether it's a non-ST elevation MI or a ST elevation MI. However, from a practical standpoint, at this point we need to know how many medications am I going to put my patients on? Antiplatelet, anti-lipid, anti-inflammatory, etc.
That's a very good point, Mirvat. And we actually have yet to understand who are the base patients to be treated with this drug. In one way, the patients that have been included in this study were not so selected, so they were roughly unselected patient population. On the other way, we have seen no remarkable side effect of this drug. So there were just a minimal increase of inflammation-related increase of pneumonia in colchicine treated patients. So basically it seems from the trial that most of the patients could be addressed with the drug, but an important and novel field after this trial will be to select those patients who probably can benefit the most from this trial, who are the patients with the residual inflammatory risk after an MI.
And so that's probably where inflammatory markers will come into play to identify those patients further.
That is going to be probably the hot topic in the future, to understand who are the patients that are to be treated with this drug, and probably also during the follow-up, how to understand if the patients are responding or not. So in a way, like we are doing today with LDL, with statins, there probably will be some markers in the future that we will use to understand if we are keeping the inflammatory risk under control.
Absolutely.
So Mirvat, we also have seen in this yesterday, during the first day of the AHA, the presentation of the recovery trial.
Yeah, so this was an interesting trial that actually was very controversial. What they had is 145 asymptomatic patients with what they called very severe aortic stenosis. And they defined very severe as a mean gradient of more than 50, or a valve area of less than 0.75 centimeters squared. And the results actually showed a better outcome in the patients when they were intervened on by surgical aortic valve replacement early, even though they were asymptomatic. Now, of course, the conservatives were very annoyed by this study, suggesting that we're being too aggressive and that we're, but keep in mind that these are still a very high risk patients because they have severe aortic stenosis, and symptoms are actually very subjective in this patient population.
So we know that that from the patient, especially in this kind of patient population, patients tend to not feel the symptoms, to not note the symptoms, just because they adapt their lifestyle according to the symptoms, and many of these patients maybe would never develop symptoms and may die suddenly. So this is kind of a paradigm-changing study, although the number of patients was very low. I mean, this is really something new, and the paradigm change that can affect potentially practice.
Absolutely, and another limitation, of course, is the echo parameters that they use. You know, the echo parameters may not necessarily be reproducible, all of them, and sometimes from day to day, the same patient, their parameters do change. And so we probably need to define very severe a little bit more stringently based on imaging and echo parameters. But we have some imaging data that show that once fibrosis does develop, even when you replace these valves, the LV function does not recover. And so it is an area to explore, but it still needs further exploration. And of course, we may need to address it now that TAVR is becoming an alternative to surgical aortic valve replacement, but it opens the door to a lot of other questions: which valve and what risks level STS risk score are going to be involved here, and so on.
Absolutely. I mean, considering the fact that these patients were treated with with surgical aortic valve replacement, a treatment with transcatheter valves it seems even more interesting. I don't think that it will take immediately its space, and I think that there are trials that are already ongoing on this field for TAVR, but it's going to be important to explore this in the future.
Yes, absolutely.
It has been an exciting day of science at the scientific session of the American Heart Association 2019 in Philadelphia, and thank you so much for your attention, and hope we will get some good science to discuss upon also tomorrow and the day after tomorrow.
Yes. Bye.
Bye.